For the module on epidemiologic study designs, this is the lecture segment on ecologic study designs. So this is the last segment for this module. I'm just going to take an opportunity while we're looking at the outline here to review. So we talked about the counterfactual concept that the ideal way to learn cause and effect would be to be able to look at exactly the same person in the exposed or treated and exactly the same person in the untreated and unexposed condition and see the outcomes of both of those. Not going to happen very often. So the best choice, failing that, is the randomized trial where individuals are randomized to exposure or unexposed, treated or untreated status by the investigator. So as we're going down the outline here, we're going from the randomized trial, which is the highest confidence in our ability to infer cause and effect because it's the least susceptible to biases and confounding. And as we go down the slide, we are getting slightly more and slightly more and slightly more opportunities for bias and confounding in our study, and therefore our confidence and ability to infer cause and effect gets weaker. So the randomized trial was the best. Cohort study is a close approximation of a randomized trial. It's just lacking that randomization step, which is so important. So our confidence and ability to infer cause and effect is somewhat weaker. Case control study is weaker than a cohort study because it's potentially more susceptible to bias. Not telling you not to do a case control study, I'm just telling you to be very careful in your design and how you carry it out to avoid those biases. Cross-sectional studies have their purposes for studying prevalence and the health of the community, are very important studies. But as soon as we try to take completely cross-sectional data and infer cause and effect, we are opening ourselves up to a lot of bias problems. And then finally, this last segment is going to be about ecological study designs, which ecological comparisons on their face may be among the weakest evidence for cause and effect, but yet I'm going to get to some exceptions at the end where we have some really interesting cause and effect data that are from ecological studies. So I guess it's kind of a never say never conclusion of the lecture. So key features of ecological studies: there's no random assignment. The units of observation are groups of people. All the other designs that we've talked about in this module have been individuals are studied. Even when we talked about group randomized trials, the randomization occurs to the group, but the outcomes of every individual in the group are separately measured. So ecological studies, that is not the case. So the data, it's pretty much a situation of using already existing data that tells you something about groups of people. So, and then disease frequency in each group is compared or correlated with exposure frequency in each group. So some examples might help with this. So first, just sort of a theoretical data layout. In this case, the vertical axis is the aggregate disease frequency. So if each of those dots is, say, a state in the United States, how frequent is your disease of interest in that state? And then going across the horizontal axis, is the aggregate or group level exposure frequency. So how frequent is your hypothesized cause in each of those community level measurements, and how frequent is the disease outcome? And if we're seeing a correlation in that graphic, people love to leap to the conclusion that there must be a cause and effect relationship, right? So an example, this is total mortality among men in U.S. states and Canadian provinces by proportion of income received by the poorest 50% of households. So the vertical axis is the mortality rate, the age-standardized mortality rate per 100,000 population for each state or Canadian province. So way up at the top of mortality, we have Mississippi, Louisiana, Alabama. And then down low, we have all the Canadian provinces down low on mortality, and also New Hampshire and Minnesota and some other unlabeled U.S. states. And then on the horizontal axis, we have what is the median share of income received by the poorest 50% of households. Or in other words, in each of those states or provinces, how severely is a portion of the population impacted by poverty. So in this case, they are drawing a correlation between poverty and age-standardized mortality rate in these states and provinces. So perhaps on the face of it, compelling, because there's a pretty neatly fit line there. But you have to stop and ask yourself, okay, so what else is different among those states and provinces besides just poverty? That's a typical thing of ecological studies, that we have picked out one characteristic of these units. Often they are geographical units comparing countries, comparing states, and you've picked out one characteristic, but what's to say how many other characteristics may also vary among the same groups. Another problem that we have with this type of data is the mortality, the people who are actually dying, who are the incident, who are the contributing to the mortality rate. Were those all poor people? Were very many of them poor people? So whether poverty is related to mortality, we don't, obviously plenty of people who die were not even affected by poverty. So a couple of problems with ecological studies are, again, that you're looking at some kind of aggregate measure of exposure in a group, but plenty of people within the group may have had a whole range of exposures. Really, they don't have one uniform exposure. And then the potential for confounding for a lot of other characteristics to differ across those groups, besides the one that we happen to pull out for our graphic. Another example, correlation between per capita fat calories and breast cancer incidence rate per 100,000 women. Japan is characterized by a very low per capita supply of fat calories, and also a very low breast cancer incidence rate. The United States and some other European and Western countries have a very high per capita supply of fat calories, and also a much higher breast cancer incidence rate. But again, how many other things are different between Japan and these Western countries besides just literally fat calories? So in fact, people, based on ecological comparisons like this, many studies have been launched trying to do cohort or case control studies demonstrating association between fat in the diet and breast cancer. Pretty much we're never able to bear this out very well. And again, how many other things might be different among these countries that might also be related to breast cancer incidence? All right, so why would one use an ecological design? It may be that exposure is more variable across groups than within groups. People say that it's hard to find anybody in the United States who has as little fat in their diet as an average Japanese person, or they used to say that. So if exposure truly varies across groups so strongly, that might be a reason to do an ecological study. It's also the case that there may be exposures that are actually population level. So policies and laws are not individual level. If you ask one person in a community and another person in a community, what policies and laws are affecting them, they may not know, but they should be the same ones if they're in the same communities. Healthcare systems are another example of potentially a population level exposure. Ecological studies are very frequently done with already existing data. Some certain types of aggregate measures that, you used to actually have to ask someone for data, but nowadays you go on the internet and you can get a lot of data about aggregate characteristics of geographical regions, right? So it can be very quick, easy, and inexpensive to do a study if all the data are already on the internet. Ecologic studies have often been used to help an investigator generate new hypotheses. So the hypotheses about dietary fat and breast cancer that launched many studies of other designs. And then again, if disease or exposure prevalence itself is of interest, like the cross-sectional study, the ecological study may be very valuable just for that purpose alone. So a lot of advantages, or a lot of pluses for ecological designs for some specific settings. But in terms of inferring cause and effect, what are the problems with ecological designs? First, similar to all observational studies, there may be unmeasured confounding. There's the challenge of knowing whether in time exposure actually preceded outcome. So similar limitations to the other observational study designs we've talked about. And it's very difficult to infer individual level causation from group level association. So this is referred to as the ecological fallacy. So again, if you're really trying to focus in on a cause and effect question, I'm not encouraging you to go out and do an ecological study. On the other hand, if there's data that already exists that you might be able to look at to create some kind of preliminary hypothesis generating analysis, that might be an interesting thing to do. So I'm going to give you an example. So now I've just bashed ecological studies, right? I'm going to show you an example of really where ecological studies are very compelling. So despite these limitations, some ecological comparisons can be informative, including cause and effect. So these are data about cervical cancer mortality trends. I'm showing you 3 countries, Finland, France, and Romania. The paper, if you want to look it up, actually has a lot of other countries in it. And so it's cervical cancer mortality in relation to cervical cancer screening or PAP tests, right? So I'm told that there was never a randomized trial of PAP tests for screening and prevention of cervical cancer. There was never a randomized trial. So talk about a test that is incredibly widely used, the number of people, the number of tests, it's just huge worldwide. It's pretty shocking to think that no one did a randomized trial to demonstrate the effectiveness of this test for cancer prevention before they started using it. But in fact, the test was out there as a diagnostic test, and it just sort of like caught on. I'm not sure, this is before my time, but it started being used, in the clinical settings before there had ever been any studies to demonstrate the efficacy as a screening test. So after the fact, in 2009, and there's other studies along the way, but this is one that was published in 2009. They pulled together a whole lot of ecological data about cervical cancer screening and cervical cancer mortality, and they looked at it by country because they said that there's some countries that had a low burden of cervical cancer to begin with and well-organized screening, which is Finland. So you notice the vertical scale, Finland starts out fairly low, and as the screening gets implemented in the 1970s, 80s, 90s, cervical cancer mortality is going steeply, steeply down. And they have the paper has other countries that they feel like also had well-organized and widespread screening, right? And then they used in the middle France, which had a relatively low burden of cervical cancer mortality to begin with, and what they describe as non-organized but widespread screening. And then finally, Romania, which these authors describe as having a high burden of cervical cancer mortality to begin with, and a low level of screening throughout this entire period. So the little blue dots are cervical cancer mortality rate, deaths per 100,000 per year for each year on the graph, and then the red line is the slope. And so this is really quite compelling. Try to think of an alternative explanation why in some countries cervical cancer mortality would be dropping drastically. In other countries not that far away geographically, cervical cancer mortality would not be changing. And if you look at the paper, and they have like dozens of graphs like this, they studied a lot of countries, and it's a fairly compelling example. So one more ecological data. So actually there were other types of studies with good cause and effect evidence for association between folic acid in the diet and orofacial clefts as a birth defect. So this is some, after the United States, based on other studies, implemented folic acid fortification, then people did some ecological studies to see if the incidence of orofacial clefts actually went down. And so this is a study that's showing that. So pretty messy data, right? The prevalence of these orofacial clefts apparently has a lot of random variation in it, but the slope of the correlation is somewhat convincing. So again, for the most part, an ecological study is not ideal for cause and effect questions, but especially going back to this other example, it's hard to imagine when you're looking at the same population over a period of years, what else might have changed during that time that could have affected cervical cancer so dramatically. So this is not studying different populations and comparing them to each other. It's studying the same population, Finland, the same population, France, over time with one variable that would affect disease that has changed strongly. So, and then again, the same population in the US with variation over time. So that's where ecological studies have a little bit more validity, is when you're looking at the same population where some things have changed over time. Okay, one other thing that I want to mention is similar to cross-sectional measurements used in other study designs. Investigators may use variables measured at the ecological level in other study designs. So again, we talked about things that are naturally occurring at the group level, policies, air pollution, and so on. Those ecological variables may be validly used in a case control or a cohort study. So that's all I'm going to say about ecological studies. And then there are some other study designs that are mentioned in your textbook chapter and you may encounter in the literature: non-randomized interventions, family studies, studies looking at genetics in terms of family relationships, and case crossover studies. And people may describe all of these as also fitting under the rubric of epidemiology, but for the purposes of this class, we're not going to further address these types of I would call these kind of specialized study designs. We're really going to be emphasizing mostly cohort and case control studies for the rest of this class. So that's the conclusion of the lectures on epidemiologic study designs.